but first two talks are open for comments and questions. And while you are thinking of questions, I'd like to ask Dr. Acharya, for a patient today who presents with NAFLD and advanced HCC, what will be your choice of treatment? Eligible for systemic therapy.
Well, you mean a patient with fatty liver disease who has a good liver function and a large tumor burden with or without vascular invasion, who is not fit for surgery or ablation and also not fit to undergo, right, SBRT or transarterial radioembolization, or he has a vascular invasion. And that is the stage we were asking very specifically, because HCC treatment is individualized and depends upon the stage. Now, if you see both IMBRAVE trial, which has been published, one in 2020 and one was in 2023. And IMBRAVE 150 trial, which shows patients with good liver function with advanced HCC, the hazard risk reduction is about 40%, roughly. Even progression-free survival or recurrence-free survival, also the hazard risk around, say, 30 to 35%. In IMBRAVE 050 trials, which was used as an adjuvant therapy, atezolizumab, in those who have already HCC, have resection or ablation, in them also the recurrence-free survival was much better with atezolizumab. Therefore, this is the first adjuvant therapy. In neither of them, immune checkpoint inhibitors could make any difference as per etiology, because subsequent analyses were published. They didn't find. The data in this, the data is few, they are retrospective, and if you see, there is one clinical trial which shows that lenvatinib is better in MASH HCC than ICIs, which I showed. And there is a problem in real life, and the initial data which was shown, published in Nature, 2 data based on animal study, that if you give immune checkpoint inhibitors, the CD8 cell become more active in the animal model. So you need further data.
Your choice.
My choice in this country will depend upon patients' affordability, patients able to compliance and follow. A 3 months therapy with ICI, that is atezolizumab, cost you 4 lakhs. Now you continue to do this treatment indefinitely. Some of them can be subjected to transplant, which will cost you another 25 lakhs. Now, if the patient is well, can afford, and will like to be followed up very closely, well, I will choose atezolizumab.
Thank you, sir. Dharmesh?
So I think, sir, your talk based on the Nature paper, which was an animal model. So we all know.
No, that is a combination of animal,
and
human,
then translated to human phenotype.
Yeah.
But the problem is that the basic concept of using ICIs was to make the tumor microenvironment enriched with the CD8 cells. These particular workers showed that this phenotype of CD8 was a little different. It was pro-inflammatory and an exhausted CD8,
yes,
because they are the effector cells. But this was not translated into the clinical practice, which was shown by Dr. Shingle's paper, which you also highlighted.
Yeah.
Himalaya trial was a prospective study, and that was the only trial which showed that the viral as well as the non-viral, the response rate favored the immune checkpoint inhibitors. So there might be that there is a path in between. That means patients who've got the MASH HCC probably need greater immune checkpoint inhibition, wherein both a CTLA4 as well as a PDL1 is used. So now that we have available the Durva-Tremi combination, probably that might be the way forward for this cohort of patients. But because between TKIs and ICIs, The most important thing which our audience must understand is the objective response rate. Objective response rate, to perceive an objective response rate with TKIs is extremely difficult. It did not occur in the sorafenib era. There are some reports that it is seen in a proportion of patients, albeit very small, with lenvatinib. So I think if, like you said, affordability is there, one should go with the immune checkpoint inhibitors.
That's correct, but Dharmesh, you will agree this is not clear because these are all retrospective analysis barring except
The
Himalaya trial. Yes, there is one trial.
That uses 2 drugs.
Hi. Question for Dr. Deepa. I found your LIRAD classification very complicated. And I'm just wondering, what's the gold standard we base it on, and whether we should go back to biopsying these tumors as a gold standard rather than rely on scanning?
Which category are we talking about here?
Well,
the LRM.
All the categories, I think.
All the categories. Well, I mean, I suppose the only confusing component here compared to any other category is the LRM categories in it compared to LR5. LR5 we are pretty sure about it, but it's only the LRM that we are not sure. But otherwise it's just the 2 modalities and then the biomarker is all that is required to diagnose HCC. I don't think we should be biopsying everything, but it's only in the doubtful cases which falls under the LRM category or probably LR4. But again, the LR4 and LRM, it is just based on the imaging findings. But then we need to consider the biomarkers as well. I mean, gone are the days wherein, we probably, when the radiologist is reporting, they are not looking at the AFP or the PIVCA. But in clinical practice, if we can correlate these features with a raised PIVCA, for example, if somebody has got an LRM or an LR4, but then the PIVCA2 is, way above normal, then I would classify it as LR5. And that is why I said we should not just look at the classification, but then we should correlate with the biochemical parameters as well.
There's some value in looking at histology as a prognostic marker because those features actually help you decide what's the management of these patients. So while your classification is useful for diagnosis, we also need to think about prognosis.
Prognosis, yeah, I understand that, yeah.
What Dr. Lee is telling, the tumor biology, you see, up to LR4, we are not sure actually. Even LR3, 20% is HCC. And we know that poorly differentiated HCC is a poorer outcome. And we know tumor size is an important variable to produce alpha-beta protein or PIVCA. So there are problems individual. So what is asking that in which patients you will recommend histology, histology being a prognostic marker. And I think clinician, all of us, we do histology whenever there is a doubt, we are not very clear. Say if you have a very clear-cut LR5 lesion with very raised alpha-beta protein and if PIVCA in a serotic background, fine. But if you don't have such a situation, we look for other evidences to say 100% this is tumor. That's what I was trying to say.
I accept that, but the other thing I wanted to highlight here is when it comes to the tumor biology, the taste responsiveness is also probably one of the indicators for the tumor biology, isn't it? Rather than going ahead with the biopsy, if we are not sure, at least in our institute, we've been doing taste to see the responsiveness of the tumor. And if it is based on the tumor responsiveness, they consider either the resection or the transplantation. So that's again, not necessarily biopsy, but then we are going ahead with that. But yeah, that's something to consider as well.
Professor Acharya, the issue about etiology and its impact on HCC, one of the school of thoughts, at least in cadaveric liver transplant, was that if you say resect a patient who has HCC with hepatitis B versus non-hepatitis B, the recurrence, if it happens, would be more multicentric and the patient may not be eligible for transplant, versus say a hepatitis C where the recurrence is more at the site of the original disease. So would you consider etiology when you are deciding the upfront treatment? Say for example, a 3 to 4 centimeter tumor with hepatitis B, you may probably resect, but you would probably go for a transplant because the recurrence may not be eligible for treatment later on. So how would the decision depend when you consider the etiology?
Well, if you see, and if you have seen patients, and also if you see this study, the recurrence is biphagic. most of the recurrence will occur within first 2 years. And late recurrence occur invariably at 4 or 5 years, if you've seen in your real life practice as well. Those which have an early recurrence, they have already, right, clones of HCC there. Now there, how do you decide? You decide arbitrarily, even though there is no hard data on it, the duration of the disease, duration of untreated period of hepatitis B, right? There are many other variables which will influence your clinical decisions. Now, if a cirrhotic patient, you have one HCC, he has a hepatitis B virus, and he had a high viral load. He was a male person. He has a family history of HCC, right? Obviously, he has a high chance of recurrence. On the other hand, you have fatty liver disease, right? And there are metabolic risk factors. The tumor is there in a non-cirrhotic background. Resection is fine. There will be no recurrence. So, therefore, what you are saying here, these are case scenarios which are prevalent in a particular center. If you have a large amount of hepatitis B virus, there the recurrence rate will be higher in such patients. Whereas if you have a mass HCC and you have a resectable tumor, the recurrence will be low. You have also yourself seen in your real life, mass HCC are usually well differentiated, usually single, right? Maybe large, but they do behave much better. What we discuss is a different thing. The response of immune checkpoint inhibitors, right, in this group of patients.
Mike too.
My question is to panelists that when do you usually repeat the first imaging after RFA, TACE, TARE? Each procedure has its own duration, or what is the strategy used for that? And another question is that what is the evidence of loco-regional therapy in intrahepatic cholangiocarcinoma?
First question is, what is the strategy? Actually, strategy is depending upon the classical staging, various staging we follow. We follow Barcelona Clinic liver cancer staging. We have modified
first imaging when we have to repeat for post-RFA, post-TACE, post-TARE. Is there any difference?
If you are using TACE or TARE, you are using an intermediate HCC. If you are doing ablations, you are doing it in early HCC, curable HCC or resection.
If we need to repeat the imaging within 3 months, or usually we repeat within 1 month, and is there any difference?
What she told you, imaging particularly, if you are using radiotherapy or ablation, you may have a peripheral blast, which will be confused as the prevailing existence of tumor. Right. Normally, we follow after a treatment about 6 to 8 weeks. Variably started usually 4 weeks, but gradually after doing this, we are delaying it. Right. 4 to 6 weeks. Some people say 3 months. These people, radiologists, say 3 months. That is the interval.
The question is, how is the data on the intrahepatic cholangiocarcinoma?
If it is resectable, resection is best.
Okay.
Resection is best.
Thank you, sir.